Well, hi, everyone, and welcome again to the Musical Innertube. I'm Don Rooney.
And I'm John Timpane. You know, Don's had quite a career in radio and television, where he's been an on-air personality, a news anchor, and even a TV weatherman.
And John has been a college professor. He's written several books, and he's been an editor and features writer at the Philadelphia Inquirer newspaper.
We first teamed up for a radio show in college. On one show, we introduced a soothing musical interlude.
But we stumbled, and it came out Musical Innertube.
And that became the name for this podcast, where we talk with interesting people about their interesting lives, difference makers who've really made a difference.
The Musical Innertube welcomes back Art Caplan for another update on the COVID, or should I say COVID's, pandemic. Art is currently the Drs. William F. and Virginia Connolly Mitty Professor and founding head of the Division of Medical Ethics at NYU Grossman School of Medicine in New York City. And before that, the Art that I knew was the Caplan Professor of Bioethics at the University of Pennsylvania Perelman School of Medicine in Philly, where he created the Center for Bioethics and the Department of Medical Ethics. He's the author of only 35 books, 800 papers in peer-reviewed journals. We tried to get somebody who was qualified, but instead we invited Art back. Welcome, Art Caplan, once again.
I would, somebody asked me, do you remember any of those 800 papers? A few, but they're fading off into some obscurity.
I must say, Art, your business card must be like a page and a half long.
Well, it's also funny. I came around to the view, which I learned from a few people I admire. Shorter is better. You know, it's like Art Caplan, he's a professor. That's fine.
well, Art, you are a man with a lot to do lately and for the past 2 years. And it always seems that when we have you in, there is a lot of news on the COVID front. And I'm wondering whether a good way to start might be to ask you if, in light of the December we had and the January that we're beginning to have, I mean, are you seeing any things that are particularly surprising or particularly distressing?
Yes. On the distressing side, we still don't have anything close to the availability of testing in the U.S. that we need. And people may say, so I don't really know if I have COVID. What's the difference? If you want to reopen schools, a big debate, the way to do it is to test the kids before you send them to school, keep the positive ones home, and keep the schools going. Instead, we're having these huge fights. Do we open the school knowing that we're sending in kids who might be positive, and teachers and staff as well? And then we're going to have to close them, and then the parents are going to have to come back from work, and they're going to have to find daycare out of, all of a sudden, and blah, blah, blah. That's really disappointing. And I'll add further. It was disappointing when Trump didn't do tests. It's disappointing when Biden hasn't done tests.
Yes.
We just aren't doing the right thing on tests. Another disappointing thing, mixed messaging. So CDC comes out and says, if you are positive, you can stay home 10 days and quarantine. Nope, stay home 5 days and quarantine, but maybe wear a mask. Well, that messaging is confusing. Let's be generous about it. So
that's what everyone is saying, is that they are completely confused. Suddenly, nobody really knows what to do.
Exactly, and that should not be. CDC shouldn't utter anything unless A, it's clear, and B, if they want to change it, then they should explain why. So, if the masks don't work against this variant, hypothetically, then okay, we'll have a different policy. We learned something. But you don't just flip-flop around, and Trump's administration did it, and now we're seeing it with the CDC under Biden. You can't just say, well, never mind, you can go out after 5 days. I know what's driving this. It has to be keeping people at work. I was telling Don just before we got on the air, I can't take the train to work into New York City from Connecticut because there aren't enough people to staff the train. They're all out sick. Now, they're not dead, but they're out. They don't feel good. And the CDC and the government don't want that. They want things to be running, and they want people to go to work. And okay, that's fine. But admit it, fess up. It's like, we're not going to insist that you test. A, we don't have tests. And B, We want the schools to run and the trains to run and the airlines to be able to fly, and that's what we're doing. But they're not saying it clearly.
I know. Stephen Colbert had something on his show where he said one of the suggestions for a 5-day wait as opposed to a 10-day wait was from Delta Airlines. And he said, well, you figure if they had a variant named after them, they have a dog in the game. But it does seem like the CDC has caved into pressure to try to get everybody back to work and everything back to normal, even though it's not normal.
Right. And I don't even care if they fess up to it. Then we could all decide, well, maybe they want me to go back to work, but I'm staying in 10 days anyway. But at least I know that they think it's stupid. We don't have tests. And then Art can't ride on his train, which is a tragedy. So we're going to say 5 days. Fess up to it.
Why don't we have tests? Are they sitting on a shelf somewhere? Is it a supply side issue? I know that the Biden administration has just announced who gets the contract for the supposedly 500 million tests that are going to be mailed out. I mean, 500 million tests. First of all, 500 million of anything is hard to get out to everybody, right? But I'm just wondering, where are the tests? Do they exist? What are the big issues in getting them out to people?
So, listeners, that question is the rest of this podcast.
I'm sorry. You see, I'm trying to make it as easy for me as possible. If I could keep the number of questions we ask down to a minimum, I could just kick back and hear your smartness. But no, I mean,
sure. John and I can go to lunch now, and you could take over.
You'll still be talking like in 3 hours about the test problem. So
it is also what's on everybody's mind, isn't it? Where are the tests? Why can't
the tests don't exist? They have to get made. That's point one. Why they aren't made? Because Trump, in his wisdom, decided I'm going to push vaccines as the answer to this. Remember, he said, I can't even believe I have to say this, we're not going to test because that just makes the numbers look worse.
Yeah.
Yeah,
I do remember that.
We don't want to look bad.
Don't want to look bad. So he completely bailed out on testing, did not fund it, bought nothing. Remember, the reason we got vaccines, the warp speed part, was that he said to the big manufacturers, Moderna, Pfizer, J&J, we're going to buy these vaccines from you in advance, whether they work or not. I mean, it was a pre-purchase, and the pharma company said, well, that's a good deal. Okay, we'll make a lot of vaccines. I hope they work. Now, it turned out they did, and they had, a good breakthrough, but he didn't do that with tests. So, A, they don't exist. B, we don't have good tests. We never did test the tests adequately. So there are, you guys know, nasal swab tests that go deep, nasal swab tests that don't, saliva tests, and for all I know, there are other cuckoo tests being offered somewhere, sweat tests or whatever. None of them really verified and tested the way we did do the vaccines. So we don't have tests, and we don't really have a minimal standard for what we expect from a test. If that wasn't bad enough, right, and John just said this, we don't even have a system to distribute these tests. So let's say Biden gets his 500 million tests, which I'm going to sneer at in a minute, but let's say he gets them. So they come in a big warehouse outside of Glenmead, Pennsylvania. That's where they are. Who's trucking them? Who's moving them? Are we going to say, come by, drive up, get your free tests? What's the distribution system? There's no distribution system for getting out tests. Now we can do it another way. Go to your CVS. Go to your Walgreens. Go to your other big chain pharmacies.
Rite Aid. Yeah. Mm-hmm.
Anybody been in those stores lately? I mean,
yeah, I have, and the only thing that I've seen is big signs that says we have no COVID tests.
Yeah, they also say we have no employees, we have nothing else to sell you, we're completely overwhelmed, and good luck to you. It's like, oh, well, that'll be good distribution of tests. I'm looking forward very much to making sure that people don't cheat or get 2 or 3 or whatever. Now, 500 million tests, John said correctly. Making 500 million of anything safely and getting that done is no small feat. Let us remember that We've had at least one delay in vaccines when an entire plant in Baltimore was pulled offline because of manufacturing problems. I will guarantee you that contract, if issued today, will not produce 500 million tests until the fall, earliest possible. It's just tough. You're making medical products here, even if I said we haven't tested them adequately to make sure they really work. But let's presume, we'll be generous. Let's say they do. It's going to take a long time to make them and distribute them. Just a long time. Now, you want the sneeringest part of all, if anybody's still awake after this speech?
Yes, please.
All right. 500 million tests. That's a lot of tests. How many Americans are there?
338 million.
So we can look forward to each one of us having one test. I mean, what are we talking about here? 500 million is great. What you need is like 5 million tests. You need like 20 million tests. You're not going to get far with 500 million tests. It sounds like a huge number. It is a huge number. It's a manufacturing challenge, but it's not the answer. So that's been the number one failure in the past 2 years about COVID, not making huge volumes of tests, both for us and the world. You can't vaccinate your way out of nearly any disease. There are a couple, smallpox, almost polio, but generally you got to test. You sometimes have to quarantine, sometimes have to mask, and then you have to vaccinate. We've been like vaccinate, and that isn't enough.
It's amazing to me when I consider that about a year ago, the Biden administration started pushing for 70% of the population. We got up to about 57% as of July, which the Biden administration called a victory of sorts.
Right.
It is now at a whopping 62%. So in almost 6 months, we got 5% more vaccinated. So, I mean, I think we're looking at one of the reasons you can't vaccinate yourself out of a pandemic, even if you could, with all the best intentions in the world, and acknowledging that it went up a little bit. It seems as though it's sort of, I wouldn't say ground to a halt, but gotten really slow, the growth in percentage of people having at least one shot.
Right. So I'm full of sneering today. You got me on a great day for sneering. First of all, one shot shouldn't even be in the numbers. One shot doesn't do anything. So what do I care about one shots? I care about 2 shots. And with Omicron, I care about 3 shots. You know what the percentage is on the 3 shots, which I think is the real complete vaccination? It's about 18%. So not good. And 18%, I mean, there isn't, let's put it this way. I know there are vaccine resistors and vaccine opponents and so forth, but 18% is a pretty bad number because the resistance isn't that big. So what is going wrong? It's partly that we've sold 2 shots is what you got to do when it's probably 3 shots is what you got to do. And I'm going to predict here, we can all assemble next year around this time, it's going to be an annual shot. This is not a lifetime protection. Most vaccines are, you have to get, I hate to use this term, boosters, but you have to get revaccinated.
Yeah. Yeah, the idea too has started to permeate that that COVID is going to be around the way flu is, and that every year we're going to have to deal with it, and we'll probably have to deal with some sort of mutations. So, how do people get their head around the fact that this pretty deadly disease is going to be with us forever?
My third sneering answer by a funeral plot. I mean, people say, well, we'll deal with it like we do the flu. Oh, great. There's only 50,000 deaths a year from the flu. I mean, we don't do well with the flu. You know anybody who got a flu shot? I mean, I did, but
yeah, I did too. Yeah, I always get one.
Generally, they stink at getting flu shots.
Right.
If we're going to say I'm ready to live with it the way we live with the flu, I'm not happy because we don't do well with the flu. Too many people die of the flu. And by the way, at NYU, at Penn, places I've been in relatively recent times, the flu overwhelms the hospitals just like COVID is now every January and February.
Yep, right now.
Have to triage, the staff is getting sick. It's a mess. So saying, we're going to deal with COVID like we're going to deal with the flu is like saying, we're going to hire a new coach for the Jacksonville Jaguars who'll do just as well as the prior coach.
Well, you're now hearing a new term, and we don't mean to be laughing about this because these are all we're pointing out difficulties in the system. In fact, real failures in the system, some of which are structural. But we're now hearing the term flu-rona. A certain number of patients are now being seen in hospitals that basically have both viruses.
Yeah, well, and of course it would be nice to know which they had, but there are no tests.
Right, there isn't a test for flu-rona. And because the symptoms, and I was going to ask about that. How did they sort out the symptoms? Because they can look a lot alike.
Absolutely.
Yeah.
I mean, you really have to test to see who's got a flu virus, who's got a COVID virus, who might have both of them, which is possible. That you can definitely have both. It's not common, but it happens. But again, you got overwhelmed hospitals right now, pathology labs trying to run their COVID tests. I'm going to say, well, I believe this is the fourth sneering thing I've said. This is a record in 15 minutes. So you see numbers about Flurona or who's got COVID and not. If we all do a bunch of home testing, do we report that to the state of Connecticut, the city of Philadelphia, the mayor of Harrisburg? No, we do not. We just sit around and say, hey, guess what, Don? I tested negative. Kind of interesting. You tell your friends. You tell people.
Right.
We're under measuring. Who knows what the level of COVID is? The numbers you're seeing are the ones that get reported. I'm going to say that's a fraction. I don't know what fraction, but it ain't close. Flu testing at a time of COVID has probably dropped to next to nothing. So even though people think it's around and not good, not adequately measuring that either. So surveillance, just monitoring what's coming around, that's a public health gap. And we could fix it. And I hope we do. Build more labs, build more surveillance. What I'm talking about here is every year you should just take patients who come into the hospital and give a blood sample, whatever, and take 2% of them and test them to see what diseases they've got and set up some sentinel system, and then you know what's going on. That we can fix. That's some happy news.
And I think intake at public hospitals could include something like that, right?
Sure.
Intake in the hospitals that everybody goes to when they don't have insurance. For example, at USC Hospital, that kind of testing could happen at a place like that.
And remember, we're not asking for additional samples. It's just if you have to give a blood sample for some reason that you're there, then we'll look for COVID and flu or whatever other viruses. Well, we've got your sample. It's just, and we don't need your name. It's just surveillance. I don't care if it's John or Don or Art. It doesn't matter. We're just measuring, prevalence, as they say.
More with Art Caplan in a moment, but first, this soothing musical Innertube. Art Caplan is the MIDI professor and founding head of the Division of Medical Ethics at the NYU Grossman School of Medicine in New York City. Before that, Art was the Caplan Professor of Bioethics at the University of Pennsylvania Perelman School of Medicine in Philadelphia, where he created the Center for Bioethics and the Department of Medical Ethics.
Art is the author of 35 books and 800 papers in peer-reviewed journals. His books include Vaccination Ethics and Policy, The Ethics of Sport, Replacement Parts, The Ethics of Procuring and Replacing Organs in Humans, and The Case of Terry Shavo, Ethics at the End of Life.
Art is among the best known and most influential medical ethicists in the contemporary scene. To learn more about Art, see his page on the NYU Medical Faculty website. Just go to med.nyu.edu, click on the faculty box, and type Art's name, Caplan, in the search box. And now, back to the musical Innertube. I'll give you another chance to sneer here. The reports that we've had from people who have been boosted, double vaxxed and boosted, are, hey, I have COVID, but it seems really mild. The other reports we've been hearing are that people who are hospitalized with the Omicron virus are people who have not been vaccinated. So is there a telling measure in that the vaccination at least takes the edge off it, and you have a very mild case of it?
Well, again, a little bit of skewed sampling, because some of the cases that go in to the hospital, let's say I had a heart attack, maybe they test me for COVID too, or they don't. They're probably going to try and treat my heart attack and not worry about whether I have COVID, and that'll go to the side. You show up with the symptoms, difficulty breathing, big fevers, you're going to get tested for COVID. I will say this. We do know that of the people who are in the ICUs, way, the huge percentage are unvaccinated. Right. No vaccination at all. Mm-hmm. So that's probably 75 to 80%. I looked at actually, it's funny, I don't know the NYU number, but I do know the Philly number from buddies there, and it's 80% in the ICU unvaxxed.
So you're telling us that in the country's ICUs, about 80% of the people that are being seen in those intensive care units across the country, something up to 80%, let's say that, have no shots.
Correct. Zero.
Okay, I'm just taking that number in. So
now there are others there who've had one shot, which I dismissed as meaningless. Mm-hmm. Not a big number, but a few. And then there are probably another 10%, let's say, who've had the 2 shots. But we already know that the 2 shots aren't sufficient against the new variant. So it's not hugely surprising, but it does send the message, again, confused messaging. I had 2 shots, and my grandpop is still in the ICU. Well, that's because what we really needed was 3 shots, but the messaging hasn't been clear. We all take pride, even the Biden administration, when we were putting out those numbers that we've been talking about, it's a 2-shot number. It's not the 3-shot number. So, I find myself banging my head on the wall at some point and just sort of like, yes, it definitely helps to have the 3 shots. And the people who stay home and have the symptoms, it seems anecdotally that they're the 3-shot crowd. I can't prove that. But the people who are in the ICUs, I know who they are. Unvaxxed, 1 shot, 2 shot.
I wanted to just stop and ponder that number a little bit, because it talks an awful lot about not just about disease, but about, our social structure. And although I don't want to go out on a limb on that for right now, it's something to put in our pockets and talk about another time, because ICUs reflect society and they're the safety.
You're right, John. They're the safety net. Everybody goes there. Very few places send you a bill to get in. They may do something later, but entry is not contingent on showing a wallet or something.
Yes.
No. And the other thing I want to mention, you guys will love this as an ethics issue. A few people have asked me, coroners and medical examiners, when the family says don't list COVID as cause of death, is that okay? So if you want to talk about underreporting problems, this thing has gotten so ideological that families don't want to admit to others that their loved one died of COVID, and they ask that it not go on the record. There also may be some worry there that some of the insurance companies are starting to say, well, if you didn't vaccinate, maybe you're not going to get benefits from your life insurance policy and so on. But even measuring who's dead from COVID is partly a political question. It isn't just, I tested you, you had the virus, I know you died from respiratory or kidney failure.
Yes, who has the greater degree of rights in a case like this? I mean, I'm just sort of zeroing in on the ethical questions. I mean, does the family have the right to keep such information private against the community's right to know the true prevalence of a very contagious disease?
You got it.
And
it seems, corners, just as a cousin issue, they don't like to write down suicide. So I know suicide rates are underreported because out of courtesy and kindness to the family, they don't always put that down as cause of death. I think it's wrong because I think these are public records, and I think you have to know it's one of the few surveillance things we've got if you're going to do suicide prevention or you're going to decide how to spend your budget or COVID or whatever it is. But people say to me all the time, well, at least we can study coroner's records or medical examiner's records and get an adequate sense of what's going on. And I have to say, I don't think so. There's a lot of attention, and I'm not ignoring the point of protecting family sensibility.
I've also seen articles coming up recently saying things like for people who have high-profile people, high-profile vax deniers who then get COVID and pass. Yeah. We shouldn't gloat over those people dying because, it's not the right thing to do. But on the other hand, is there any value in making an example of people who have been high-profile vax deniers who then get COVID, then die from it, to say, look, this is what we're talking about all along?
Yeah. Don, this is funny. I wrote that. I mean, I'm the trigger of the gloating debate these days. And by the way, gloating has its place. I lived in Philly a long time. I'm an Eagles fan as a result. I gloat when the Dallas Cowboys die. I don't pull back. I think I sneer and laugh and act like a teenage jerk or something. And I have other situations where I've been known to gloat about something. And all of us, I'm sure, in our lives have heard the term schadenfreude, right?
Yeah.
Right.
Oh, well, that ethicist didn't do so well on his TV performance. Not that I'm watching or competing, but maybe voting there, whatever. Anyway, so I get it. There's human nature there. But I think you can criticize. You can hold people accountable, but you shouldn't gloat. And the gloating part is sort of sneering or making fun or diminishing the grief of the survivors and so on. I don't like that for two reasons. I don't think it's inherently right in those circumstances. I don't gloat when somebody dies of drunk driving because I think it's bad to drive drunk. And I'm not going to gloat about somebody who never exercised and then died, but ran around saying exercise wasn't necessary or something. There's a flip of this. I remember a little gloating when some of the fitness runners were dying. John may remember this. There was gloating about, look at runner X. He's dead at 35, and he said he had to run.
Jim Fix.
Yeah. That's it.
Yeah.
But the main reason is I'm trying to convert them to get vaccinated. So I think if I'm gloating about the death of their mother or their sister, I don't know that that's going to be an effective message. It's tough.
Surely you can take an object lesson from these stories. And in many cases, people who see that they're not going to make it, some of them have left statements.
Yes.
Or have written some things saying that they were sorry that they took the path that they took, that they now realize this is real. And
great with that.
Yeah.
And this will appeal to both of you as in your journalism parts. If I was giving some CDC advice, I'd say tell more stories. Tell more narratives. That's what sticks, not facts and numbers alone. Say, here's what happened to Joe non-vaccinator. I'm not gloating about it, but I'm just telling you, maybe they expressed regret at the end. Maybe they didn't, and they just died, and they died pretty miserably. That's what we're trying to avoid. I see all these campaigns on now for don't smoke, and I think they have effect when they have people saying, this is a hole in my throat, this used to be my chin, but it isn't anymore, or I'm freaking out because I'm not going to be around to watch my grandchildren grow up. That's not gloating,
right?
But it's tough.
Yeah. As a journalist, I'll tell you, especially working in television, you get sent out a lot to the neighborhoods of people who have died to ask neighbors what they thought of these people. I've had a lot of those type of assignments.
Yeah.
But I have noticed that there's an extreme lack of that on the local level and the national level of talking to people whose relatives died of COVID, or of talking to patients who are in the hospital with COVID. There's a story popping up occasionally, but generally it's just a rundown of the numbers and talking to a local pediatrician or a local infectious disease doctor about it. But there's not a lot of those human interest stories that television loves so much.
You know what got me to take driver safety seriously was when they put the wreck of the car of somebody who went to my high school on the front lawn, and you walked by it for a year.
Right.
And I'm not saying everybody put away their beer or acted, but it was a better message than just saying, 10,000 kids die every year because of drunk driving or something. That was a message.
And I think the message, I have no numbers to back this up, but I think the practice of having a designated driver when everybody decides to go out drinking that is far more prevalent now, partly because of campaigns like that. That it's easier to select one person and say, okay, you're driving tonight, and the rest of us will have some drinks. And that does seem to be more prevalent than it used to be. You don't have, I have no numbers on this, but it's my impression.
Yeah, I think so. By the way, one other thing, as long as we're talking about messaging, I had a little inspiration over the past couple of weeks. Normally I try to lie down and suppress these when they occur, but this one I thought might have some merit. I'm trying to organize a group of our med students to agree that they're going to give one talk on COVID a year and then get the thing to spread to other med students, nursing students, vet students, and then hopefully even to real nurses and fully trained doctors and veterinarians or whatever. They're not out there at the Kiwanis Club, at the 4-H, at the church, at the whatever, you know what I'm saying, local civic things. The anti-vaxxers are there. They're at the school board meeting or whatever, but
sure,
there's no movement among the scientists, and I love CNN and I'm on it, and I like the New York Times and other things, but talking to people who believe what I do, more or less, isn't necessarily going to dent much on COVID. So, people say to me, you do a lot of podcasts. Yeah, I hope that we get heard in Harrisburg, and I try to go to at least 4 or 5 poor places in the U.S. every year to talk to some church group or something, because nobody's going there. But they're the ones who only have one source of maybe poor information, let's put it that way. Anyway,
yes.
So maybe a little better grassroots communication here, I'd say, to the CDC. Get them out there, and you'll notice I didn't even say anything about what I wanted them to say. In all honesty, I don't care what they say. Just get out there and bring some science or health or public health perspective.
Well, surely, Art, this is something that states could easily adopt. I noticed that Florida has, let's put as gently as possible, an interesting Surgeon General.
Yeah.
And they've come up with some interesting ideas. For example, they've told students at universities that you don't have to get tested or vaccinated. We're going to concentrate on more, on populations that are more vulnerable to this. Now, it sounds good on the face of it, but it also means that probably in-person learning is done for the year. You know what I mean? There's just some things people don't think about, but also statewide, they've sort of gone very easy on testing, very sort of try to, even saying, to the point of saying, really testing, what does testing really tell you? This kind of thing, But to go back to the point, surely if we're going to do this messaging thing, it's something that on a state level might be more effective if it could be adopted. I mean, you could have a Republican get up there and give a COVID message that wouldn't sound at all, it wouldn't sound at all partisanized, and some have. So some certainly have, and some certainly have statewide. And I know in Maryland, for example, the governor's been squarely behind a pro-vaccination message, and he's a Republican, and so one knows it can happen. Hogan, yes, very sensible, I think. Because there's so many mixed messages, it would be great, again, if priests and ministers and rabbis would make time, for their congregations to hear not one, perhaps several stories about folks.
And again, I'm not here to say, I didn't say, here's the message to carry. I'm not going to issue a template. If you're a conservative Republican and you think that the Florida experiment, or what sometimes is called the Swedish experiment, also sometimes called a failure, but let's put that aside. Nonetheless, if you think that's right, I don't care. Just bring the science perspective that you have to bear. Then people will ask you scientific questions, and that should improve the level of debate beyond Joe Rogan anyway.
Yeah, and maybe some survivors, some people whose loved ones have passed, could talk about what they've undergone and what their loved ones went through.
And I pick my students too, because they see it as young people in the ICUs. So they have stories. They know what burnout is. They've seen people die. They're new. So, they're not hardened to it or.
Right.
Yeah.
A fresh perspective.
Yeah.
Well, hopefully
We'll
this
see.
this podcast is one of the things that's getting the message out. Cross your fingers. And thanks for being with us again, Art. And we'll probably be talking to you in another couple of months about some new twist in COVID.
Gosh, I hope not, but I fear so. Not because you guys are bad. It's just I never thought I'd have to be living in a 9-year COVID epidemic. My God.
Oh, goodness. Well, thank you, Art Caplan. We really appreciate it.
Thanks, guys.
Thank you for listening to the Musical Innertube.
You can get in touch with us by email. We're at musicalinnertube, all one word, @gmail.com.
You can follow us on Twitter at @MInnertube, capitalize the M and I.
Our webpage is musicalinnertube, that's musical spelled with 2 A's, .libsyn, that's spelled LIBSYN.com.
The Innertube is available on Amazon Music, Facebook, YouTube, Apple Podcasts, Stitcher, Spotify, SoundCloud, iHeartRadio Podcasts, and anywhere you get your podcasts. Like us, why don't you? And give us a good review on any of those platforms.
And as always, thanks to virtual band Car Radio Dog for our theme music.